Good afternoon, and thank you so much to everyone in person and online for joining us today. I am Alexa Smith, and I'm the Educational Exchange and Event Program Manager with the Office of International Programs. And we are excited to launch our 12-part series in conjunction with Dr. Archie Headings in the Department of Orthopedic Surgery as part of a series under Foundations of Global Health. Just a little bit about what Foundations of Global Health is. Global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. And that is from the Consortium of Universities for Global Health. Global health is a varied and rich discipline to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world, this ongoing programming through the Office of International Programs is designed to feature those in our KUMC community engaged in the field of global health. KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. Presenters will share their personal journeys, educational backgrounds, mentors, books and articles that gave inspiration, challenges, lessons learned, successes, epiphanies, life-changing moments, and even the heartbreaks. The series is meant to provide a platform for both presenters and participants to participate in conversations while developing foundational knowledge and exploring best practices for engagement in the discipline of global health. We will be back a week from today on October 1st with part 2, a brief overview of the African Trauma Initiative, this room and on Zoom. And now it is my privilege to introduce Dr. Archie Headings. Dr. Headings is a practicing orthopedic surgeon in the University of Kansas Health System. He is also director of an international orthopedic trauma fellowship that focuses on alleviating disparities in trauma care throughout Africa. Dr. Archie Headings.
Okay, thanks everybody for coming today. And I hope that if you get anything from this, it is how you can take some field of study in medicine and apply it on a global level. Because that is one of the biggest challenges I had when I got into orthopedics. So basically, what is the African Trauma Initiative? This is a series of lectures. Today is the first one that we're doing. About the African Trauma Initiative. What is the African Trauma Initiative? Well, the purpose of it is to combat the growing trauma epidemic through the development of self-sustaining orthopedic trauma centers in Africa. But how did that come into being? And I'll talk a little bit about that. I don't want to give too many spoilers because most of that will come out of our lecture next week. And today we just want to focus on what is orthopedic trauma. But these two men right here on this slide, the gentleman to the far left is Dr. Solomon. He was one of our first fellows in the International Orthopedic Trauma Fellowship. The other one is Dr. Abby. And both of these first fellows of ours, when they came to learn orthopedic trauma, it became very clear that as they were going through their training, that if we did not get them the equipment they needed, that they wouldn't be able to practice the things they were learning here. And then in addition to that, as they went back into practice back in Addis Ababa, it became very clear that they didn't just have enough, they did not have enough operating rooms. And so then that started this campaign that we're currently working on to build them a hospital. So one thing, and particularly as medical students or nurses or physical therapists, you know, when you go into medicine, and particularly for students, because I remember when I was going into medicine, I felt like there were two paths to take. Either I could take this clinical path where I treat people and treat individuals, or there was this path of research where you could go down this career of trying to discover a cure to a particular disease. or trying to discover a new surgical technique. But one thing that I think will come out of this talk and these series of talks is that you do not have to discover a cure to a disease or develop a new surgical technique to have a huge impact on the health of others. Okay, you don't. Said another way, we're going to take that a step further. The impact of a discovery or advancement in medicine does not end when it just reaches your sphere. What am I saying there? There's lots of things we do here that you're learning as medical students or that our nursing students are learning in terms of how they treat illness or disease. And we practice these in America. But if you think about it, if you go to a part of the world where these things aren't practiced, well, it's as if these discoveries have never been made. So we all think and hear about, wow, what an impact the measles vaccine had on America, or what an impact joint replacements have had on America, or you name the surgical technique or the medical technique. But when you take these techniques to a part of the world that haven't had them before, that is a huge impact. And you can do that without being a researcher. You can do that with by being a clinician. And so that's what we're trying to do through this African Trauma Initiative. So the African Trauma Initiative then took off by Kim Conley is here on the far right here. None of this would happen without her. And then on the bottom here, as you had this is a Jack Nolte, then Jack Aries, and then Jonathan Dahlman. And those were the three founding medical students for this. This wouldn't occur without the work of these medical students. And for the medical students that are here that are on the team, so much of the work of this is done by medical students. And then finally on the end is Adam Goodyear. He's someone who stepped in. He's an outside orthopedic surgeon that offered to use his skills to train our fellows in arthroplasty. And then it's grown into this, and you can see several people here. Yep, you're up there on the screen. Cameron and Joey, yeah. So, so many people are on, and this just goes, it's gotten so big, really big, even larger than that. So there's so many people involved in making this happen. And it's a multidisciplinary approach. But again, a lot of it is centered around orthopedic trauma. But let's start first with just what is trauma? Because there's a lot of confusion around that word. When we talk about trauma, if we just get to the origin of the word, it's from ancient Greek, meaning a physical wound. So if you look at the definition of the Merriam-Webster dictionary, it's an injury such as a wound to living tissue caused by an extrinsic agent. How much trauma is there? There's quite a bit. It's not the leading killer. So these are 2016 numbers, and they're the total number of deaths caused by injuries. If you look over here, can you see my pointer? Sorry, I'm getting used to this. You can. So, but if you look at this, injuries, they're not the major killer. They kill about 5.6 million people per year. They're less than cancer, less than ischemic heart disease. They are currently now more than HIV, malaria, and TB combined. So they account for quite a number of deaths.
A lecture for orthopedic trauma.
But where are these deaths occurring? 93% of these deaths are occurring in low to middle income countries. If you say to yourself, I just don't see a lot of people dying of trauma. Well, that's because 93% of these 5.6 million deaths are occurring in low to middle income countries. So this is kind of getting at that point I was telling you about. The impact of a discovery in medicine doesn't stop when it just reaches your sphere, right? There's a whole world out there that they don't have the advantage of having trauma care like we do. Not only that, deaths due to trauma are continuing to increase. They're not on the decline. If you look at these numbers of infectious diseases, HIV, malaria, TB, they're continuing to decrease. But trauma deaths are projected to increase, a 40% rise by 2030. They are increasing, not going down. And who does trauma affect? Well, primarily trauma affects young people. It is the leading cause of death among those 35 to 45 years of age and younger. So about from 5 to 35 to 45, that's the major killer. And that leads into the next slide. Because when you talk about, this is an academic institution, we love to get grants. And when it comes to getting grants or money, when you talk to somebody and you say, we need some money for doing research in trauma. And a lot of times you might get pushed aside by somebody saying, well, ischemic heart disease or cancer, I've actually had this happen. It's killing more people. I would argue, what is the effect though of that? And here's what we're going to look at this a little bit closer just for a brief second. Some brief facts about cancer deaths. The peak incidence for cancer deaths is 90 plus years. I'm not saying that people 90 plus years of age should not receive good medical care. I'm not saying that at all. But when we talk about trauma and who it's affecting primarily 5 to 45-year-olds. What is the impact on society when somebody in that age range dies versus somebody in their 90s? What is it? And then if you look at ischemic heart disease, the average age for someone sustaining a heart attack, their first myocardial infarction, it's in the 70s. So again, it is something that affects an older population. It's important. It is important. But if you look at this graph right here, it talks about disability adjusted life years. So it talks about what creates the most disability in the world. This is a 2016 graph. But if you look at it, it's injuries. And why? Because the impact is on a younger population, a mother, a father who can no longer support their family. That impact is profound. It's profound. Moving on. So trauma, it's the major cause of disability in low to middle income countries. If you look at this map, this is called the heat map. It comes from the World Health Organization. You can log on to their website and it will, show you all sorts of things you want to look at in terms of where's the place in the world that has the highest amount of cancer. This is on road traffic mortality. And what do you see there? The darker the green, the higher the concentration. And where do you see the highest concentration? It's in Africa. Road traffic accidents, the highest concentrations in Africa. Trauma, the highest concentration of trauma in the world is in Africa in terms of trauma deaths, trauma disability. What is it that's killing people? This just shows you, that the main killers of people are first road traffic accidents. After that, it's conflict-related violence, either interpersonal or war. Then it's self-inflicted harm. So somebody trying to kill themselves. And then finally, it's falls or other types of injuries that we'll see in work-related type things. So that's what's killing people. That's what's responsible for the majority of those 5.6 million deaths. Again, 93% of them occurring in low to middle income countries. Well, why do I have a picture of a house? Here's why, because the reason why we're going through this is if we want to alleviate this problem that exists in low to middle income countries where they don't have this medicine that we have here, we have to have people understand how trauma is treated. Okay, it's a system. It's a system of taking care of trauma patients. So if you think of the human body as a machine, we're going to compare that to a house, right? And there's many ways houses can get injured. You see, there's a house that's been shot up by lots of bullets. That's a good example of penetrating trauma that we see. There's two types of trauma, blunt and penetrating. So there's penetrating trauma, and then there's blunt trauma. I've got several examples of blunt trauma. You see this car that flew into a house, a plane that went into a house, a tornado, and then that lady sitting in front of the house, that's artillery. So, but if you wanted to reconstruct these houses, what do? Right? Well, you're going to need carpenters, you're going to need electricians, you're going to need plumbers, you're going to need an HVAC person, heating, ventilation, cooling. You're going to need a structural engineer, windows, trim carpentry, siding, and painting. And if you think about that, that's what we do. That is how we treat trauma. If orthopedics, if you had to take the human body, when a human body is broken by trauma, either by a tremendous amount of blunt trauma from a motor vehicle accident or penetrating trauma from, bullets or an explosion, the frame is disrupted. And who reconstructs that? Typically are orthopedic surgeons. The electricians, well, I would call that the neurosurgeons. The plumbers, you can think of those as our general surgeons. So it's a whole, just like you have a team that reconstructs this house, this mechanical structure, it's the same way when it comes to reconstructing a human body. So what is orthopedic trauma surgery? It's a field of study focused on reconstruction of the musculoskeletal system following traumatic injury. So here's a good example. This was one of my patients. He was in a motor vehicle accident, head-on collision, I-70. She sustained bilateral femur fractures, used to carry about a 50% mortality rate with it. Now we're down to about 17%. The frame is disrupted. What do we do? Treat it with an intramedullary nail, plate and screws for the femur fracture on the left, plate and screws for the both bone forearm fracture. And you can see how that basically reconstructed the patient's frame, kind of like the framer of a house. That's what we do. Seems so simple, but it has a profound effect on someone. Here's another example. It's not just plates and screws or rods. Sometimes a bone is damaged so bad that you can't do anything other than to replace it. And so we've got some good techniques to do that. This person was initially treated with a plate and some screws. This failed. The majority of the time this works, but it didn't work in this patient's case. And they got a hip replacement, a new joint. Here's a patient that was in a farming accident, had an open proximal humerus fracture, could not be reconstructed. The patient got a joint replacement. So there's lots of tools we can use in reconstructing the skeletal frame, and these work. They work really good. And we're going to go through that. So what are the effects of untreated orthopedic trauma? We don't see this. We don't see this. But let's just take an open tibia fracture. The mortality of open lower extremity fractures, femur fractures, tibia fractures in the 1800s, mortality rate was 81%. We don't see that today. People don't realize when they come in with an open fracture, we're treating them, we're saving their life. That is a life-saving procedure. And it was even said that your chance of survival was 7 times better if you fought all 3 days of Gettysburg versus sustaining a gunshot wound with an open fracture to the lower extremity or a similar fracture by being run over and were treated in a city hospital. These were medical writings back in the time on how dismal it was if you sustained an open lower extremity fracture. The first series of management of open lower extremity fractures without a death was not until 1884. It's fairly recent that we have these, and the risk of death with non-operative treatment of, jumped ahead. And that came after Lister described his antiseptic technique. So it was a big, that obviously changed a lot in terms of medicine. So what you see here, this gentleman who's got the tibia fracture there, that's an open tibia fracture. I've kind of blotted out, obviously the open wound, but that is a life-threatening injury. To the left of that, what you see is it's called a Montesia fracture. It's commonly sustained in children, and it affects the elbow. And you can see if you sustain that injury, you really don't have good function of your arm. So if you don't treat orthopedic trauma, the effects are you can die, right? Or you can be so disabled, you really can't work. Here's some other examples. You see a femur fracture, this one on the far right. This gentleman survived. But you can see it happens if your femur heals like that. What do you think you're going to do? Well, he's unemployed. He's on disability. In fact, he had a chronic decubitus ulcer that could not heal until we corrected this malunion that he had. Here's a gentleman next to that, just to the left of that femur x-ray, is a gentleman that sustained a femur fracture, but it was treated in traction. He was doing okay, but you can see that obviously caused him considerable disability. And then here's a gentleman that sustained an injury called a Galeazzi fracture. It's called the fracture of necessity because if you don't fix this, the patient's going to do horrible. And he has tremendous disability with this arm. Has chronic open wounds here where that ulna protrudes through the skin. And you can see the bone is kind of eaten away because of a chronic infection there. So fractures are the most common outcome of an injury requiring treatment. So you can see that without orthopedic surgery, people can become disabled. They can die. And then over the years, we've developed a good field of study, a good school of thought where we treat these type of injuries and we can have a tremendous impact on the patient. So if you look at all injuries, and what you're going to find out in subsequent lectures is if you look at the operating room volume of trauma centers, the subspecialty that rules the operating room in terms of the most numbers is orthopedics. And here's one of the reasons why, because the most common outcome of an injury requiring treatment, it is a fracture. And who treats those? and for the most part, orthopedic surgeons. So in addition, musculoskeletal injuries account for the majority of disability following trauma. 78% of injury-related disabilities are the result of a musculoskeletal extremity injury. How much time do we got? I just want a time check here. 12 minutes. Okay. All right. What we're going to do is we're going to go through a brief little primer on orthopedics because I just want to talk through what you have to understand, what type of training you have to undergo if you're going to take somebody who sustained a significant injury to their musculoskeletal system and then fix that. So when we take our residents through an injury, the first thing you do is you just learn the typical anatomy. So this is actually taken from a lecture that I have on tibial plateau fractures, and we just start out with the basics. Here's a knee. The knee is made of 4 bones: the femur, the tibia, the fibula, and the patella. And these are the views that we get of it. Typically, an AP view and a lateral view. This is normal anatomy, and you need to familiarize yourself with it. Then we get down into what are the parts of the knee. So you have a medial tibial condyle, you have a lateral. This is your lateral plateau, and this is your medial plateau. And then here's the lateral, that's the lateral plateaus in red and the medial plateaus in yellow on your lateral. So, okay, so you familiarize yourself with the normal anatomy. And then we get into how does this break? If you apply too much load to the musculoskeletal system at the knee joint, how does it fail? And this is one of the ways it fails. And it fails in a very predictable fashion. I don't know why it was a shock to me, but it was so interesting to me as I traveled the world and I would go to other hospitals and I'd see injuries and everybody broke the same way. I don't know why you would think that maybe they break differently in Africa. No, they don't. We're all human. We all fall the same way. We all get in car wrecks the same way. If you're trained in America on how breaks occur, it's the same way in Africa. It's the same way in Romania. It's not any different. It's the same in China. So this is, and bones break in a predictable pattern. And because of that, we can tell our residents, we can take them through this and say, when somebody falls in this manner, when somebody gets in a car wreck, this is how their frame's going to fail. Look for that. And it can make you look really smart, but it's just because you know what you're looking for. So this is called a split depressed tibial plateau fracture. This is called a medial tibial plateau fracture or Schatzker 4. And we know this pattern is associated with arterial injury. So it can be limb threatening. So if you see this pattern, you need to get an ultrasound to make sure that the artery is working. So there's value in learning all this. This one's called a bicondylar tibial plateau fracture or Schatzker 6. Also can be associated with vascular injury. And now let's talk about the mechanisms that cause them. So if you apply a load like this to the knee, say you're playing football and somebody strikes you with their shoulder from the side, what happens? It's this, right? And it's important to understand that because you need to know the forces you're working against when you reconstruct this. They typically have a valgus malalignment. What if you get struck from this side? This is your Schatzker 4, and you can see how it kicks the tibia all the way over out laterally. It's a knee dislocation, and that can rip the popliteal artery. Or this, you fall. And what does that do? It gives you that, right? You'll see if anybody gets into orthopedics or anybody, works in the operating room, you'll see because what we do is we counteract those mechanisms of injury when we're reconstructing these. So here's a bicondylar tibial plateau fracture. How do we treat it? Just put that in your mind. What we've done is we've applied this called an external fixator here. And you can see there's 2 pins in the femur above and some pins in the tibia below. They're connected by these bars here. And by applying traction, just by applying traction to counteract that axial load, Sorry, I went crazy with my animations here. Um, so you pull on this. Here we are before. Look at that. Yeah. All from just we call that the pathophysiology, just by you understanding how did this blow apart, and just by you having that understanding, counteract that, and that one simple move makes you look really smart. You didn't do much. So, and then you can take that blown apart thing. Now it looks like this, right? And all you did was pull on the leg. You spend all this time studying right now, all these things you're memorizing, and then the answer to this problem is pull on the leg. So, and I appreciate the smiles, yes, because you memorize so much. You memorize so much, right? Okay, let's talk about outcomes. So here's a horrible plateau fracture sustained in a, because it gets to the point. This is good work. Orthopedics does good. It saves lives. It changes lives, right? And so here's a young man. He was in a motorcycle accident, sustained a bicolumnar tibial plateau fracture, had a popliteal artery injury, vascular surgeon intervened, got his blood flow restored. We reconstructed him. You know, this looks kind of crazy. It looks like somebody dumped a bucket of screws into his knee. But I promise you, there's thought put into this. You know, and here he is. You know, he's walking normally. This is one of the fractures I feel like I see commonly overseas that's not treated. People will come in with profound disability. So here's another case. You know, sometimes people lose limbs. As we go through these series, the advances we have in prosthetics here, people in lower to middle income countries don't get to take advantage of. This gentleman was in a sleeper in a semi, and the semi flew off a bridge, and then it burst into flames, and then he lost his legs below his knees, but we were able to reconstruct this pretty bad femur fracture. Let me go back. Sorry. So here he is at 12 weeks. He's lost both his legs, 3 months out. He had 9 kids. I really related to this guy. I've got 9 kids. He had 9 kids. So we kind of bonded over that. But he had to get back up and work. He had that many kids. He can't be down. Talk about a motivated man. Yeah, he sent this to me on his phone, but because he was out of state, he was a trucker. But yeah, to think that somebody could lose both their legs, and to tell you, I have a number of patients that lost both their legs. There was one. All right, now you can wait. There was one time, a couple of winters ago, they closed the clinics due to snow, and I said, I'm going to be here. I don't want to have to deal with the aftermath of my patients not coming in, and then they pile all your patients. If you miss a clinic, then what they do, the schedulers, is they just take those patients that weren't in that clinic and they just shove them in other clinics. Tessa's really familiar with this. It can be very painful. So I said, I'm coming in. I'm going to be there. I came in. I sat there the whole day. My patients knew I'd be there. They could come in. Not one patient, one patient showed up, and it was a gentleman who had, there was snow everywhere. It was a patient who had bilateral lower extremity amputations. So, yeah. So people can function really well. And he was a bricklayer, bricklays with bilateral lower extremity amputations. So it's not just lower extremity trauma. I've talked a lot about this. This is upper extremity trauma. I think you can see that. This is scapula. It's blown apart. This guy got his arm caught in a PTO, a power takeoff, had a vascular injury associated with this. You can see these vessel clips here from them repairing an axillary artery injury. But your hand above your head. Here he is, right here. He's got his arm, right? And this is one of this saved a life, by the way. I mean, if he didn't have his axillary artery and his arm would have died, he would be dead. So not only did this prevent disability, but this saved a life. Overall, outcomes after serious trauma are good when appropriate trauma and rehabilitation care are rendered. So I want to, I got to, we're going to do a couple things. I thought this was kind of a powerful animation, so I'm just going to play this for you because I think it will bring home kind of everything we've been talking about. how that hits. And it's kind of an older animation, but it's not hyperbole. That is not hyperbole. That's real. Like I have patients like that. Because I thought, well, you're going to show that, and it's so animated, and but I have patients like this. When I first saw that video, it kind of gripped me emotionally because I know that patient, not the one in the Sistine Chapel. I never helped somebody in the Sistine Chapel, but I know because that's right here. I have two of my patients. This is Denise and Stan. What I talked to them yesterday because I want to know if I could use their story because Stan had as a dream when he retired of starting an area where people could just go and get away and just rest. A retreat, not a resort, because I called it a resort. First they said, do not call it a resort, call it a retreat. And what he does was he went and made a series of tree houses, which they're not actually tree houses, they're kind of built around these trees, but they're places where people can come from the city and get away. This is in Leavenworth, Kansas. It's called Hidden Valley Wilderness Retreat. And he fell when he was making this tree house here. And he fell and he sustained an acetabular fracture. And other injuries as well, but we reconstructed him and they put me in that cabin. They gave me a gift certificate and then they put me in that treehouse. And then when I got there, they said, this is what he completed after you put him back together, which was really kind of nice. And then and then Denise, actually, she ended up falling too. These haven't fallen anymore, and we fixed a fracture on her as well. So they're both living very full, productive lives. So that was a tremendous gift to them. But then, I talked to Denise. I said, what is it like having this retreat? And she said, I've encountered things I never would have expected before. She said, for example, I now know if I see a young woman or any female scheduled to come out here by herself, I need to be a little bit aware of that. And the reason why she's had two ladies that have rented out these units and with the intent of going out there and killing themselves. And she talks to her tenants and she says, in both cases, there was one in particular, she just went and talked to the gal and she got to know her and she didn't kill herself. I mean, because she got involved with their lives. So it's this whole ripple effect. When you talk about, when we try and measure things in terms of disability of life years, when you save the life of somebody in the prime of their life, those connections they form are incredible. You wouldn't even think about it. This is a couple that's in their retirement even, but they put together this resort, and you wouldn't think an outcome of putting somebody's acetabular fracture together might be that some young woman didn't take her life, but it is. It's an outcome. It's a very interesting thing. So anyway, the point is, this is good medicine, but it doesn't exist for everybody. But the work we're doing is to try and bring this to everybody. So, okay, that I'm just 5 minutes behind. So happy with how that worked out. So we're going to go to our panel discussion. So today, I have with me a number of my team. Tessa, my clinic nurse. And where's our Zoom? How do we pull up the Zoom? Alexa, help me out. Lori, my OR nurse. And then we have Tiffany, our nurse practitioner who takes care of patients on the floor. And then Heidi, my administrative assistant and transcriptionist. And it's really important that, and there's much more on the team, by the way, but I think when you look at this, you could get the impression that
you've come to save the day.
okay, all there is treating orthopedic trauma is you just need an orthopedic trauma surgeon, and then that guy falls from the ladder, and you put him back together, and that's it. But that's not just it. That's not just it. If we're going to do good orthopedic trauma, and if we're going to do it in lower to middle income countries, it's not done just by a fly-by-night type of technique. They have to have well-established healthcare systems that are optimized for treating. And that means they need a team like we have here. So for our panel discussion, we're going to bring up members of our team, and we'll just open it up for questions in terms of, what it takes to get somebody from point A to point B after a major trauma like this with respect to orthopedic trauma. Hello, Kim. Okay, I see. And Kara. Okay, so any questions? Yes, just.
Okay, so, the way you had presented a little bit,
Yeah.
Just as you said before, it takes a whole team, but there's a lot of structures in place, and I think that's kind of important to maybe understand because I don't know all the structures in place that bring a trauma patient all the way to from the injury to the end. So, what kind of structures are necessary for us to take, a patient that has a fall, has a traumatic injury? What's the process that they go through until they can come back to your clinic and you can say, hey, they showed me this video of them walking?
That is a great question. Let's work through the whole team. So here's what we'll do. So number one, I'll just start off with patient comes in the hospital, they need appropriate diagnosis. So, and as we gave that one fact, the most common outcome of an injury that requires intervention is a fracture. So somebody sustains a significant fracture, let's say a femur fracture, I make the diagnosis, and I say, I need to do an intramedullary nail. Schedule the patient for the operating room. Pass that mic to Lori. Lori, what does it take? She'll tell you. Do I just show up in the operating room and everything's magically there?
Yes.
And who are the elves?
There's a lot of magic elves.
Exactly. Talk to us about that.
Yeah, well, so yeah, there's a lot of kind of organizational elves that have to go into this. And one of that is it's scheduled. First, it's scheduled through either nursing or schedulers to the operating room. And then it might come through a team leader. So each service has a team leader and they'll see, okay, well, this case is scheduled. So they'll pick a preference card for that particular case. So then there's a team of people and who will pick all the instruments and all the supplies so that they'll make sure everything's ready, and then it gets sent up to the operating room. And then that morning, myself or any operating room nurse, I guess, and a scrub tech will be in there and we'll get the room set up, and that can include getting whatever necessary bed that we'll use, any necessary equipment that didn't come up with the instruments and the supplies. So tourniquets, that kind of stuff, other equipment, positioning devices for the during surgery. Usually an anesthesia person is in there also getting things ready. And a lot of times in orthopedics, we use radiology. So I'll need to call radiology and we need to get, a C-arm set up. So we have this interdisciplinary team, even just in the operating room. And then we'll open the supplies and open the instruments to make sure everything is sterile. So if there's anything that, happens in that process too, like if an equipment is not sterile or it's not working, we need to get a new one, or we might need to reschedule the surgery, or I am just rambling.
No,
So
but, it's what you're illustrating though, I think, is how many people it
yeah,
takes
right. So
to get the operating room ready.
yes.
And the person who heads that, by the way, I've been in these committees where we talk about problems that can occur in the operating room, and then we say you always have to make somebody responsible for a problem in the operating room, and who we make responsible is the circulating nurse. That's Lori's job.
Yeah,
So,
that nurse.
yes, right.
Yeah,
You
we're
coordinate
coordinating a lot of the things. We're coordinating with anesthesia. We're coordinating with the pre-op nurses. We're coordinating with, radiology. We're kind of the coordinators before the procedure, during the procedure, and after the procedure, we hand it off to the PACU nurse, who generally after that point, we won't really be involved. But then they'll go on to recover and then maybe be seen in clinic later. And I can pass the mic to Tessa.
Well, let's see, is Tiffany on? Is that?
Yeah, I'm here. Then pass them on to me on the floor.
That
And
is
then
so
at
much
that
fun for joining. So talk a little bit about that. What does that involve?
Sure. So we admit the patients to the floor, and generally we start involving other teams as well if they have comorbid conditions. Sometimes we'll consult internal medicine to be involved with that piece of it, so we can, focus on the fracture care, and they can help out with the medicine portion of their recovery. And then if they have infection needs or open fracture needs, we'll treat that with antibiotics and also consult infectious disease if it's a really nasty open wound. And then the anesthesiology pain team, we get them involved if the patient needs a block on the floor to help with local pain medication for pain control. And then sometimes we'll have, the, can you guys hear me? Because I can't hear you responding.
No, nobody.
Oh, okay, good.
Here.
So we get their pain under control. We have the therapy team involved with helping them mobilize, and just making sure that their wound care is done. I'll have Kate jump out of the OR sometimes to help me with splint care, and just making sure that the patient is wrapped in a bow before they leave the hospital and they're stable.
And Tiffany, if you don't do your job, will patients die?
I mean, I don't know if I'd go that drastic, but they are at risk for a higher mortality. Yes.
It's the truth. It's the truth. Tiffany keeps patients alive. Even for that matter, same with Lori, when it comes to getting equipment ready for the operating room, her making sure that like cell savers in there, that blood's available, all these things.
Yeah.
If you, right. It's if you want to deliver trauma care, and if we're just talking about orthopedic trauma care, it really takes a large team of thoughtful, trained people. And then let me ask you this, what's the toughest part of your job?
Making sure all the T's are crossed and the I's are dotted. I feel like if you don't have every little piece of the puzzle put together just so, then things can go wrong really quickly in these frail patients.
That's right. Yeah, and you do an excellent job at that. Then they get discharged, and that leads to Tessa, my clinic nurse. So talk a little bit about that, Tessa. What does that involve? Getting patients from point A to point B, graduating. You're the one that graduates them.
Yes, we get them to the finish line and all healed, which is very fun to witness and be a part of. So patients, I would say I've been thinking about this since you kind of asked me to define my role. And I've noticed a lot of my job is psychological coping because patients kind of go home and they're like, what the heck just happened to me? And I have all these questions I couldn't think about when all of it was happening. So just a lot of coordination of their follow-up appointments when they're in clinic, helping with wound care, fulfilling any orders Dr. Headings needs me to fulfill to take care of them on the outpatient side. And yeah, like I said, just a lot of talking on the phone and sending messages back and forth with just answering all their questions and making sure they have peace of mind through the whole ordeal.
I'll tell you, Tessa keeps people alive too. Tessa has to, the tough thing about Tessa's job, and Tessa's been, how long have we been together, Tessa?
11 years in October.
11 years. And she makes it look easy. But the problem with patients once they discharge is you have stoic patients that present tiny complaints that are life-threatening, and then you have patients that cannot cope, and they're presenting minor problems as life-threatening. And somehow Tessa has to differentiate between the two. And it is so true. Her point about being like a psychologist or a counselor is he has to have this skill of reading people, even over the phone, and determining, is this a real problem? Or is this something I can talk the patient through? It cannot be emphasized enough. Patients die directly as a result of their trauma. Patients die in the trauma bay, if not managed appropriately. Patients die in the operating room. Patients die on the floor. Patients die after they get discharged home. If you look at the mortality of some of these injuries, you know, it's like it's not just you make it past the first hour, you're okay. It's not that way. I mean, you got to get them quite a ways out. So lots of things can happen along the way.
Dr. Headings.
Yes.
Ooh, that was really loud. So sorry, you guys. Hey, I know a few of us have to go to our professional development at 1, but I wanted to ask a quick question for people who may be curious. Can you kind of talk about how people are able to get involved with IOTC and kind of the African Trauma Initiative, and kind of what it would look like for them to be involved at this step in our development?
Yeah, thanks so much, Cameron. Well, we really, the whole reason why we launched this lecture series is we want to broaden our reach. We need people. We want to raise awareness. So, and all throughout KU, this is a large project that involves the School of Architecture, the School of Business, the College of Liberal Arts and Sciences, as well as, you know, here at the Med Center, nursing, you know, medicine, obviously. So, if you're interested, you can email me, for the nursing side, you can email Lori. Lori's the director of the nursing fellowship. On the medical student side, you guys have a mechanism for bringing in medical students. I know that. And I do kind of defer that to you guys. So
If you want us to talk about that, we can. I just wanted to make sure other people were, well, we're going to have a rotation that'll come in November, where we send out applications for the new M1s that'll be welcomed into the program, where applications will be sent out and interviews for those positions. And we'll select 3 M1s for the new ATI group. And that's kind of like a funneling system for that. That's for the medical student side specifically. But that's about how it goes. Is there anything I'm like forgetting? Hope not. So yeah, should be good.
I got some comments on the
Doctor,
chat.
yeah, there's a question in the chat. To places like here in Africa, most especially in Uganda, where we have very few trauma and orthopedic surgeons at large, what are the most things as a student at the emergency department that should be done, or those that shouldn't be done in a patient who comes with an open fracture?
Timon, the most important thing is administer antibiotics as soon as possible. And the type of antibiotics you give depends on the degree of soft tissue injury, as well as bony injury and degree of contamination. So antibiotics, and here we typically use Anstef for grade 1s, and then for grade 2s and 3s, we'll use Unison or Zosyn. So antibiotics, tetanus prophylaxis, and then it's a matter of cleaning the wound and stabilizing the wound. And truthfully, for a lot of open fractures, you don't have to have an orthopedic surgeon. You can simply do those life-saving things: antibiotics, tetanus prophylaxis, clean the wound, and then stabilize the wound, which can be done with a cast or skeletal traction. So if you can do just those things can save lives. Oh, Rivali, sorry. What does it look like in third world countries? Yeah, what does the process look like in third world countries? Well, I don't practice there. I have spent time in lower middle income countries, and it's highly variable. But I will tell you, I've seen situations where the trauma system is so overwhelmed, someone may be in a motor vehicle accident and they're just sent home. So, if you can imagine that. If you can imagine that, so there's nothing there. People are lying on the floor. People are lying outside the hospital waiting to get in. And then, people are sent home. There's some hospitals that have walls around them and guards, because otherwise the hospital would just be overwhelmed by people. So it's interesting, but when you have very limited medical resources, you have to protect them. And so, yeah, it's just, it can run from no care at all, period, to, you know, a little bit of something. And I have been impressed with what I've seen doctors do in other countries with not the same resources we have. So with a little bit of ingenuity and good education, it's pretty impressive how far I've seen patients brought following significant trauma. Your thoughts on that, Lori, from a nursing perspective?
Just to kind of build on what you were saying, a lot of times, if that patient gets to the point where they're being treated, kind of, if you get through that triage process, a lot of the processes are the same, at least in speaking from my perspective in Ethiopia. A lot of the processes are the same. However, they're just doing this with so much less. There's less resources. They don't have the C-arm capability. They don't have the same equipment. They don't have the same implants. They're still doing a lot of the same processes, but they're having to do it, like you said, kind of with this idea of ingenuity. So just getting into the process is very difficult there, but I noticed a lot of the procedural type of structure is the same. It's just, and they might not get sent home. They'll stay in this hospital sometimes for months at a time to recover. So, yeah, that's been my experience.
Spent for a lot of time. It worked perfect. Alexa, Kim, thanks for setting this up and making this happen. Thanks everybody for coming who participated.